Very informative. Thank you so much. So I think what we're hearing is there are many ways to do what I was calling yesterday blended classrooms. You can have various health professionals in the same classroom, and the earlier you start, it's absolutely better. And then also it's in the collaborative clinics. So some of the clinics that are the most collaborative and inclusive and egalitarian are often in our community clinics that serve the underserved. And because the dedication and the passion there of what is best for the patient and the less pressure on the economics and the medical industry in that particular environment, it really becomes, it's almost easier to create what I call a much more inclusive environment where it's very, very team-based. Central City Concerns up in Oregon is now an international model in our country because not only do they have naturopaths, acupuncturists, chiropractors, all of mainstream healthcare, they offer housing, they offer job training, they offer, placement in jobs. They really also truly address the social determinants of life. And one of the things we have learned at the Global Forum, which I think has been so useful, is so many other countries are focusing very deeply on the social determinants of health. And I think it's now really percolating strongly to the top. And also, it so affects a patient's, health. I was talking to one of our, Dom Carol Black from England and Sir Cyril Chandler at one point, and they were saying basically that if you give people housing, decent jobs, education about how to take care of their health, you can close down probably half the hospitals. And so they really are addressing this larger, broader issue. We're very fortunate, as I said yesterday, that we have access to so much care. But on the other hand, what we're seeing now is so many of our dollars are being spent on preventable conditions. And so where is our education, starting at a very, very young age, around lifestyle, behaviors, nutrition, et cetera? So as we have been hearing, and Ben so eloquently pointed out, that a lot of interprofessional education and collaborative practice is still often limited to mainstream conventional medicine in the universities. However, what we're seeing in clinics, and particularly now starting to see in hospitals, because of the recent Joint Commission statement, is that more are actually slowly starting to hire some of the complementary and integrative health professionals, as Ben mentioned, naturopaths, acupuncturists, chiropractors, massage therapists, yoga therapists, etc. And the reason that is, I think, important and helpful is that patients are accessing those persons. So it provides a more comprehensive care when you actually have them as part of the team. Okay, it's now time for other comments, other questions, other comments as well from the panelists. So please line up in front of the mics. We need to be recorded, and we have a half an hour. So, in that sense, if you don't mind just kind of watching the timing of your comments or questions, that would be excellent. Okay, we'll start here. And please introduce yourself. Thank you.
We'll hope that this is on, but I'm not a quiet
I don't
person.
think so quite. This is Anna to the rescue.
I'm Wilson Compton from the National Institute on Drug Abuse. And really nice introduction. And there's so many themes here being touched on that it's hard to know exactly which element of the riches to select. But I had a couple questions for Dr. Watt-Watson. You particularly emphasized, I think, some of the ways that Canada has been leading in pain education, at least at the undergraduate medical area, where your hours of education have been ahead of the U.S. for some time now. And from what I'm hearing from you, they may continue to be ahead of our average in the U.S. But we don't set a high standard, so Thinking about how you incorporate addiction issues, I noticed that you focus on opioid misuse and those issues. Do you incorporate a broader sense of how addiction informs opioid use and may become a very subtle part of opioid progression in those cases as part of that education? That, of course, is what I'm very interested in. But I was also curious about how you justify this curriculum, because time on these schedules for students is notoriously difficult to come by. Do you incorporate it into other related areas? For instance, the surgeons might be a particularly important target as one of the most egregious places where we see overprescribing of opioids and lack of appreciation of pain at times.
I'm not sure.
You just press on the green. Yeah. There you go.
First of all, these are pre-licensure. They're undergrads. So there is one of the patient cases is around trauma. And so they come at the appropriate use of opioids or not in terms of addiction. We try to emphasize assessment, risk assessment, and making sure that they are understanding that not everyone should have an opioid. The other option, you'll see that the concurrent sessions are a variety of strategies. And because I'm at a traditional university with 6 or 7 health sciences, or 8, they are the student. We have 1,000 students, give or take a few, and we cannot take students from outside of the university. So we come at that through the concurrent sessions, and we bring in chiropractors. We have mindfulness. I mean, we bring it in our own way. To me, we had a problem with interprofessional, the small initiatives initially, and I don't exactly know why it was new, but when we realized faculty were not interested in any interprofessional project. Students, when we went to every faculty to introduce the pain curriculum to the student body, they said, is this interprofessional? I think they had the sense it was going to be taught by medicine, if I can apologize. I'm married to a physician, but they didn't, OT, PT, nursing, really didn't want to have something. And so we emphasize this is about pain. It's the most common symptom, and it's a model, and that's the way we sold it. But you cannot work with patients having any degree of complexity unless you have colleagues. And that's what we sold to faculty, and we're still selling to faculty, because as you know, the curriculum tend to add facts. And that's what Scott and Dan are working at. It's not get rid of some of the facts and talk about competencies.
So we have 8 people lined up, so I will need to move on to
I can talk about this
next
forever, so
person, and it's all relevant. So fortunately, we will have a break after this, so please continue individually. The other side?
Hi, I'm Beverly Thorne, University of Alabama, and my question is also for Dr. Watson. Did I hear you correctly that your outcome measure is the pain knowledge and belief scale, or one of them?
That's one of them.
I was curious about that because isn't, unless I am getting scales mixed up, that's about post-operative pain management, and my memory of those questions are really pro-opioid. And it seems almost antithetical to what we've been talking about. I know that's just one.
It's our own questionnaire.
So it's not the one in the literature.
It's one, and it's not. It's across a variety of the 4 domains of the ISP curriculum.
Okay.
Yeah.
All right. I'll get that from you. Thank you.
Good morning. That was more than I was expecting back at me. Joanne Yanez, I'm the Executive Director for the Association of Accredited Naturopathic Medical Colleges. We represent the U.S. and Canadian schools. First off, I want to thank you for your presentation, and Dr. Kliegler for bringing up the interprofessional work. I had 2 points, Dr. Harrell, when you were speaking about the clinic in Arizona. And one was, we're looking at the outcomes measures for patients, but I'm curious if anyone has looked at outcomes measures for students and their preparation for the job and workforce. So that's point number 1. And then point number 2 is you brought up the big elephant, which is payment. And so, we can have the most wonderful, and 20 years ago, I worked in an interprofessional clinic for HIV patients with pain, with an acupuncturist and massage and lifestyle support and all of that. But when the funding ran out, there went the clinic. And so I think, how can we institutionalize this? And this is a question for maybe everyone. How do you institutionalize this so that, A, we're providing adequate and really good training to our students, and B, we're supporting the continuation of these programs? So those are my kind of 2 points, if you wouldn't mind. Thank you.
Thank you. We use 4 different scales for interprofessional skill competency building, and I cannot remember all of them off the top of my head. One is from the University of West England. One is the Interprofessional Facilitation Scale. That one we actually have students fill out on the preceptors. We're bringing in community preceptors as well as faculty preceptors. And so we wanted them to know how they did. And so we are measuring all of that. And then depending on what kind of environment we're putting them in, we might add some competency scales surrounding that issue, like the physician substance use competency, treatment competency scale. So we do those types of measures. And then as far as payment and moving, Terry Kennedy has a sustainability model moving from grant funding to more institutionalized methods. And I have been following that model as I work with my community partners, and so and building a business model. There is no business model out there for these kinds of things, and so I am in the process of developing some sort of model that others can use to replicate.
Thank you.
We'll need to move on. Thanks, Joanne. Thank you. Malcolm?
Hi, it's Malcolm Youngren from the Pacific College of Oriental Medicine. With the Joint Commission, there are 2 kind of components of that. One is bringing practitioners into the hospital. The other is referring out. I'm wondering if there are any models of how to refer, anyone's teaching how to refer, and anything kind of in that arena, since it does seem like it's going to be quickly upon everybody. Thank you.
Go ahead. I was just going to say, in where I am in Toronto, you're not in hospital unless you're extremely ill and maybe dying. So the people with pain are often in the community. And I think we emphasize really knowing about the other professional roles, what they contribute, what is common and what is unique. And we do emphasize that with the students.
Bo?
Oh,
sorry, Ben.
I just wanted to add that in the, not to keep touting it, but in the National Center for Integrated Primary Health Care curriculum that I mentioned yesterday, which is the 30-hour online training for primary health care folks, there's a lot of conversation about that. So there are cases that the students work through that demonstrate what the different health professions might contribute to the team. You know, what would the acupuncturist say about this fibromyalgia case? What would the naturopath say? And what would the PT say, or the mental health professional? And the assumption behind it is not that everybody is working in the same clinic, but that you're going to have a virtual team that you can communicate with kind of across sites. So it's a challenge, and the biggest challenge, which is what our challenge is in the VA, is always how to get the information back when it goes out to the community provider. But I do think that's a core part of the equation, is how do we teach about referring out to people that aren't immediately with you. Absolutely.
Thank you.
Hi, Bo Anderson, Director of the Institute of Health and Wellness at Monmouth University on the Jersey Shore. So my question is, we've heard a lot about models that involve immersing students in clinical settings or developing curriculum that are focused around specific conditions, in this case pain. And Ben, you've mentioned developing a interprofessional curriculum for primary care providers, but what about some overall guiding principles for developing curriculum across all the professions? And then, but thinking about that, is there really transferability? So if we develop something for primary care, is that going to give us a good idea of curriculum, didactic curriculum development for the other healthcare professions?
Well, I think there's enough in common. I mean, all the health professions are aimed at the patient, right? So I think some of the deeper, you may not expect every profession to have basic competency in delivering mind-body therapies or motivational interviewing, but I think there's enough in common, at least from our experience with the primary care one. There's a surprising amount of common across the health professions. And so you want to take that on, Bo? Go ahead.
Yeah, I'll think about it, Ben. Thanks.
Actually, if I could just add to that, the interprofessional practice community has looked at all of our different professional values, goals, competencies, and there's a tremendous amount of overlap.
So we have another think tank brewing here, I can tell, over here.
For the Minnesota, that
Absolutely.
would be the Nexus.
Nexus, you could find it. Yep.
So Bob Kearns, Yale University, VA. I love the chart about the 17 years from the idea for a science project to dissemination, implementation. I think in the education world, it's never. That people percolate and even publish, thank you, Dr. Watson, their curricula from a local facility, and then the goal is sustaining that at the local facility, maybe disseminating generalizable knowledge, but not curricula, not specific innovations in having them be transferred to other institutions. I work in a medical school, and I can talk about interprofessional education and pain management that goes back into the 80s, right, that we've been doing there, but how much has that gone to UConn even? So I wonder if you could talk a little bit about where things stand in terms of implementation science and how that could be brought to bear on the challenges of scaling and transferring or generalizing what you all are doing in specific settings to other similar kinds of settings.
I'll take it first, then I'll let other people talk. I love this question. Thank you. One of the challenges as a clinician, I have a Doctor of Nursing Practice degree, and that is an implementation degree. It was created specifically to look at the evidence, and it was mentioned yesterday. You all know already what works for pain, and then how to implement it, and then outcome measurement. That's what a Doctor of Nursing Practice does. But I'm a clinician, and so when you look at our academic tracks, you either are a PhD and you get time out to do these kinds of research projects, you have grant writing time, you have your research time, etc., or you're a clinician track and you do not. And so I would love to see in the future partnerships between PhD and doctors of practice, whatever they may be, those implementation people, so that we can work together and have greater outcome as far as what you were saying.
Just quickly, I am a clinician, but I'm also a clinician scientist, and I appreciate exactly what you're saying. We are about to share our materials. We've had to get copyright from the university, and we are about to share. But I do emphasize it's not necessarily about handing somebody a curriculum content, and that's why we did our model on process. It is a challenge. Every setting is different, and I'm hoping those questions will guide what people will think about to make it relevant to their practice. It's a problem. I like the question. Thank you.
Good morning. Bill Boyce-Snell from the American Physical Therapy Association. A comment and a question regarding the University of Toronto initiative. First of all, comment. When I read the number of students, the number of groups, the number of teams, the word was work, and even more work. So I commend you on putting that together and sustaining that particular program. My question is, have you formally partnered with the clinical community regarding this initiative? Because it seems to me that if the knowledge and skills the students are learning are not reinforced and modeled on their clinical internships, that this is really nothing more than a nice, fun academic experience.
That's just a fabulous question. We have a lot of hospitals that are associated with the university. So the curriculum committee has representatives. All of the 90 facilitators do this voluntarily, most from the clinical agencies. The speakers for the concurrent sessions, do it twice with no money. It's very patient-focused. We don't have psychology at the undergrad level, but we include psychology, chiropractic. Social work is a very small health science group, but we include, we try to go beyond what, the structure of who is educated at the undergrad level. The community is such a huge part, honestly. That's, I guess, an outcome indirectly is that the facilitators all go back to where they work, and they've been upgraded. If they didn't know, they're upgraded, and they're volunteer. The only money we get now is a $50,000 yearly stipend from the university, but everybody else is not paid. And it is work, but it's from committed people. I don't know. We just keep selling. Everybody has a patient with a person who has pain. We all in our families have somebody with pain. We just, it's like, I'm like a broken. People see me coming and they know,
Thank you.
Yeah, so there's always someone in the audience who, is one of those people that when we landed a man on the moon, they complained about leaving footprints. So I don't want to be perceived in any way as being a nitpicker on what you're saying. In fact, I sat in the back. I'm Eric Schoonmaker, and I work within the Department of Defense at the Uniformed Services University. I'm really envious of what you all are talking about. Everything we do in the Department of Defense, frankly, everything that's done in U.S. medicine is really by teams, and yet sometimes they're poorly constructed teams, they're loose teams, they're even adversarial teams internally. So what you're doing is so very important, and I envy you. But I do want to insert a couple thoughts. Number one, this is maybe in the nitpicky range, but when you present cases in which you want to highlight opioid use disorder, I would ask as a member of the DoD, you not use traumatic amputation. In fact, wounded warriors who are the most grievously wounded, I think Trip Buckenmeyer will account for this too, are the first to point out to us they do not want to be on opioids. They do not want to be disabled by opioids. They find themselves, in fact, disabled by the very drugs that we've given them to, quote, protect them and help them. So the last person I talked to at length about opioid use disorder was a woman who was going to help her 94-year-old mom who got opioid addicted after getting a hip replacement. So
that's not the kind of trauma we're talking neuropathic. It's different. So I appreciate what you're saying.
But I'm saying that maybe mixing it up, putting the rheumatoid patient as the one who has...
actually, we're changing to fibromyalgia, so that's a very good thought. That case is not going to be repeated.
I don't want to be nitnoid about this. I just don't want
it's a good point.
I don't want to typecast any one group.
Mm-hmm.
One of the efforts of this group, it seems to me, at the end of the day, is to sort of harmonize, maybe even align across a very diverse group of people and institutions what we're doing in pain. So the language makes a very important, very important message. The one thing I've been told recently at a conference that we talked to on rehab is that it's not interprofessional, it's transprofessional. That interprofessional bespeaks a kind of subordination of everybody on the team to one view, whereas transprofessional is what the rehab people are telling me is much more egalitarian and ecumenical. The second thing is it time for us, at least some of the resistance that we hear from a lot of people in the conventional healthcare world, and maybe even David back here representing Optum could validate this, is this notion that we're building an alternative universe, when in fact what we're trying to do is integrate emerging disruptive technologies, some of which are 4,000 years old, into conventional practice. So just as the National Center for Complementary and Alternative Medicine changed their name to the National Center for Complementary and Integrative Health, could we begin thinking about this as integrative health, not medicine, and not alternative, but integrative? That's just an offering. Thank you.
Thank you. I do want to point out that the Global Forum actually held a workshop called Transdisciplinary. And so I do think that certainly the language we use is very important. So it's interesting now to hear that they're using transprofessional. And it does create a whole different tone. So please.
Hi, Beth Darnell, Stanford University. Hi. Thank you to the speakers. While I appreciate that there's so many commonalities among training different professionals from different backgrounds. There's also some specificity for each discipline. I think that goes without saying. And I just wanted to highlight that a really nice resource, this is across disciplines, but I'll highlight it specifically for psychologists, is that the International Association for the Study of Pain has curriculum outlines available free online. And this is really critical for core foundational content. It doesn't speak to the process, as Dr. Watson spoke to, but just in terms of the content, that there's, we don't want to be reinventing wheels. So I'm sort of, declaring this for a broader audience, not necessarily for the panel. Thank you.
Thank you.
Dan Carr, Tufts University. I wanted to extend the very tail end of what Beth was saying. We've had an interprofessional program from day one, although that was before the word was widely used. That was about 20 years ago, and we have benefited a lot by actually observing Dr. Watson's program and incorporating some of this. However, an observation is that the more disparate the disciplines are that one brings together, the more difficult it becomes in terms of finding a shared vocabulary or theoretical construct and perspective. For example, we've had a relationship with New England School of Acupuncture for a number of years, and at one point, those students revolted against having what we then required as a class, which was pharmacoeconomics. They said, this is too interdisciplinary, we're never going to use this, we don't want it required for us, you can keep it for the others. So you can imagine a Venn diagram coming apart, ultimately, and the further the distance between the circles, the greater the challenges. Not that one should not face them. Second to the question, looking at the importance of social and cohort and kinship function in people with chronic pain and how common dysfunction is, I wonder whether inadvertently we are delivering a kind of family therapy or cohort therapy by immersing a patient within a well-functioning social group. Because as one sits and looks at what are the interprofessional competencies, these are not qualitative, these are not morphine equivalence calculations, these are not anatomical things. What they are a set of, I'd say, generalizable rules for proper and supportive social interactions. It's a little bit how it's consistent with how patients report feeling extremely upset if they have a clinic visit and things don't go well and people are bickering and there's fighting in the cockpit. It is extremely distressing to patients. So it suggests there's an inadvertent subtext going on where by training a social cohort in the clinic to respect each other, to listen to each other's views, acknowledge each other, what we're actually doing is a kind of mini foster home or mini group home inadvertently. So it's just a question. Thanks.
Comments by anyone on the panel?
I wholeheartedly agree, which was why I included that healthy community slide. Walking the talk is incredibly important. Thank you.
And I would just add to that in terms of the well-being of the health professional, getting to live in that maybe slightly healthier family as the place that you work is a big plus.
I just wanted to suggest a solution to this idea of transferring a curriculum to another population or institution or interest group, and that would be to have a new job, a new person who is skilled at what I would call advocacy and translation. So Judy would be someone who could be a consultant that when another institution wants to use that curriculum, you would find the person within that institution that you could work with to translate that curriculum into the appropriate needs of the other institution. And that would also solve the problem that he was just bringing up about the differences of what a acupuncture training program might want, or as opposed to a massage program might want. And you again would go to the institution that's going to be using the curriculum that you've designed and find the person who can help both translate it but also advocate for it in that process you're talking about and sell it to that other institution so that they come prepared with both a curriculum that fits their needs and the language to sell it to that institution.
It's a great idea, and in fact, I have a call with a physiotherapy group from McGill when I go back home. That's I do that work and others do that work as well.
And that would be a great salaried position too, right?
Oh. I do it free.
So we have one more comment here, and Joanne, if you had another question, please come back up to the mic. Okay, one more over here.
So thank you. My name is John Che. I've worn multiple hats in my professional career, and I'm going to make comments from that perspective. But let me just say that the acronym TIE, that's a great acronym. So I would say turf and economics are essentially one and the same for all intents and purposes. We haven't talked a lot about ignorance, by the way. And prejudice and ignorance are also one and the same. So my background right now, I'm a VP of research at a public institution where we have a large number of indigent patients, and of course chronic pain is significant. Number two, I'm also a chairman of an academic department at Case Western Reserve called Physical Medicine and Rehabilitation. And number three, I'm also the president of the Association of Academic Physiatrists. I can tell you in my 30 years of practice, the field of PM&R in particular has evolved from an alternative field, if you will, to mainline. And that pathway took a lot of turns, and we had to deal with a prejudice, if you will. As the field went from, medicine went from more biomedical model to biopsychosocial model, it became more accepting. And a big important part of that was science. And so I'll take my fourth hat as a member of the National Academy of Medicine. And the reason why you're here today is because it's really under the idea there's science behind what we're doing. And I can tell you right now, the prejudice that exists indicates the threshold for accepting your science is going to be much higher than other standards. And so can you just comment a little bit about this other elephant in the room of prejudice against complementary integrated medicine, your thoughts on science and your commitment to science? And I can say that the field of PM&R has emerged out of where it was in part because we embraced the science. And even this meeting, a number of us pushed the science component as a major part of this meeting. That's where we spent so much time as a member of the planning committee on the evidence base that we spent yesterday. So it's a long words, but if you can comment on that elephant.
So you have about 10 seconds. You're saved by the bell, as we say.
You're looking at me.
Anyone?
Well, I think there's, I think it's actually a, how should I say it? I think there's a tension between pushing for research using the conventionally established methods of proof, and this is something like Christine, or there's lots of people here who could talk about that, and understanding the degree. So there's a commitment to, I would say, across the CIH health professions at very high levels to research, and there's an understanding that the kind of research that is demanded in some places by whether it's the National Academy or the NIH or others isn't necessarily right. And there are ways in which pushing, this is going to sound like a cop-out, but there are ways in which pushing the envelope of conventional healthcare practice requires pushing the envelope of research methodology. And luckily, there's PCORI, luckily there's NCCIH who are really now committed to doing that. But this is going to sound terrible. There is that whole thing about medicine changing one funeral at a time, you know? And so I think we try to walk that balance, and this is as someone who's committed to research and science, and the challenge of translation is a two-way street. And so I think people like you pushing the National Academy to look in new ways at what is evidence, that's equally important to the stuff that we're talking about on the other side. I don't know if that's a good answer or not. But
thank you. Yeah. The reason we had ignorance is that I think many of us know that education is one of the best solutions to ignorance. And so that's how we had it, how we created the acronym. I'd like to now ask Michelle to make some closing comments before we go into break.
Thank you, Liza, and thank you to the speakers for some fantastic presentations on some real genuine innovation in interprofessional education, or transdisciplinary education, as maybe we want to start referring to it. I'm hearing from the audience that we really have to think about transferability of these competencies, of lessons from initiatives like this, and how do we customize that to meet the needs of the societies we serve, the communities we serve, as well as our learning communities, which might be varied. And I'm thinking also about the next generation of healthcare providers. Most of them are millennials who are recognized as being highly collaborative, having extensive communication networks, and they are a creator society and want to be part of creating something new from the ground up. So in addition to just being amenable to interprofessional education, perhaps they really have the skill set that it will take to accelerate this moving forward. So thank you, and help me thanking again these fantastic panelists.
Yeah.